And hello, James. I just introduce you first of all. James is one of our UTAS ex-students. You graduated in 2017.
Yeah.
And you, after that, have commenced a career over in the UK. So I thought having a conversation with you would be really interesting for the students to find out about what it's like to pick your life up from here in Australia and move all the way over to the UK, what the service is like over there, what are some challenges, and anything else that you feel might be useful or interesting for the students to know about.
Cool. Yeah. So when I started with UTAS, I just assumed I was going to make a pathway into Ambulance New South Wales, but that wasn't to be. And I got declined for New South Wales Ambulance, but looking back, it's probably the best thing that ever happened to me, because now I'm like living in another city. I'm going on cool holidays. I've got like friends from heaps of different parts of the world. And so I think it's actually done me a favor to make me look at the world through another set of eyes.
Yeah, that's really interesting. And I know that some people make that specific decision to go and work over in the UK, but it was just something that you kind of migrated towards, and it's ended up being such a great thing for you.
Yeah. And I suppose the big lessons I learned when moving overseas was that when we grow up in Sydney or wherever it is, we have a life of friends and family and a network. But when we go overseas, our phone will stop ringing one day. And when we want to call our friends, they're all asleep.
Yeah, because it's like 3 o'clock in the morning or something like that.
Yeah. So, it's sort of, I suppose we have to like make an effort to sort of start and find a new friend. And to find a best friend in a new city takes time.
Yeah, it does.
As does like finding a good share house. So like, I noticed with a lot of us, the first share house we went into wasn't the one that we stayed in, but it was a good stepping stone to find, the neighborhood, the style of people, and all that sort of chemistry.
So the setup over there, it's interesting to look at, because it's a little different even in the services that we've got here in Australia. So obviously we've got one service per state in Australia, but there's a few different services over in the UK. And even in London, there's more than one service, isn't there? Is that true?
Sort of in London, there's essentially one ambulance service, but they've got different like healthcare directorates.
Okay.
So we touch on different like health departments, as it were.
So does that mean that you operate differently within different areas, or basically your role and your job is the same everywhere? Or does it change?
It can slightly. The UK is a lot more about alternative care pathways. So in different areas, there'll be a different care pathway for mental health, or perhaps a home treatment team, or like going to urgent care centres and that sort of thing.
Yeah, that's really interesting, because that's something that within us, not just New South Wales, but within Australia, we don't do very well most of the time, or all of the time. Everyone just goes to emergency, goes to hospital. Whereas over in the UK, they're very much more about being proactive and getting that person to the specific care that they need. And I think it's a fantastic structure, and hopefully it's one that we'll move towards out here.
Yeah, so during the day, we would, if you want to leave somebody at home, depending on if you're a newly qualified or you're a qualified person, you can call their GP during the day, or at night time we have like a 111 sort of general health line where we talk to a doctor. So if you want to leave somebody at home, you can have a clinical discussion with the GP.
Yeah. But it's interesting when you talk about leaving someone at home, because ultimately you're responsible for what happens to that person. So you're the one who's going to be making those clinical decisions. Do you feel that, or did you feel, particularly earlier on when you first started working over there, that the pressure to make good clinical decisions was difficult? Was that a little bit stressful?
It is, especially when you start working autonomously, because you sort of think, is this person safe? Have I missed something? What if they've got like a obscure ECG? But it's all about like referring. So, or you take the NHS is quite a precautionary organisation, so they would still prefer you take somebody to hospital or have a clinical discussion with the GP or the clinical hub.
Yeah, because we've had quite a number of discussions, particularly about making clinical decisions, because the area of mental health in particular can be very grey, and there's no real set structure or definition as to when someone's at risk or they're not at risk. You need to make those decisions based on what you observe and the information that you get from that patient. And sometimes these decisions can be a bit difficult, can't they?
Yeah, so we have like a checklist for triaging a mental health situation, but then also it's pretty much always you would refer somebody to single point of access, which is a mental health practitioner who will then also assess, time critical nature.
So what's the time frame? So if you were to refer someone to them, what would be the time frame of when that person got in contact with the patient or when they saw the patient after that? Is there any time frame?
It can depend, I suppose. If somebody is like, because some patients, I suppose, have thought about suicide for a long time in their life, but may not have a plan.
Yeah.
And then others may be lacking capacity and acting, dangerously and have a risk profile. So then they would get a call back quicker or a home visit.
Yeah, that's it's interesting. There's several different services that they're starting to generate here, which is about specific care within those areas, and it sounds very similar to what you do over in the UK.
Because they sort of, in some theories, say that taking a person to an A&E ward is actually not necessarily in their best interest for mental health.
Yeah,
where they
100%.
sit there for hours and then they just get referred back out.
Yeah, it's something that we observe a lot here in Australia, or that I've observed a lot, is taking people into emergency, and emergency is full of people with many different things wrong with them. It's very loud, it's very busy, it's not very conducive to someone who really is suffering or who is feeling suicidal or anything like that. I mean, obviously, if someone's got medical conditions or they've got any drugs and alcohol on board, or they need to be screened medically before they go, then that's the situation there. But I 100% agree with you there. I think that it really is probably one of the worst places for people to go who are feeling suicidal or who are suffering from mental health problems.
And then I'm not sure the Australian situation, but there's a big emphasis on capacity and assessing capacity and retaining and explaining a situation.
Yeah. We talk a lot about that. Within the structure of the patient assessment, we go into capacity and whether people have the ability to make decisions for themselves. And I think that's important everywhere. I think that no matter what service that you work for, I think being able to assess whether that person is able to make good clinical decisions or good decisions for their health, that are in their best interest, I think ultimately important for all paramedics, really, isn't it?
Yeah, and then letting the patient also develop a sense of self-esteem and self-control.
And it really, a lot of that goes back towards that real connection that you form with the person when you first meet them, as well as developing that good relationship and connecting with them to make sure that they know that you're there to support them.
Yeah, and even in that, like, from an ambulance point of view, with a patient who's in crisis, it's just really, I think, our job just to make them feel safe, try and make them feel reassured about the future, and encourage them to, like, engage with services. That's sort of, and then just, I suppose, give them presents and let them share what they want to share.
Yeah.
But not sort of force them to re-traumatize themselves.
Yeah, exactly. Now, it's interesting that we've kind of gone off on this tangent a little bit more into that, which I think is very useful for everyone to know. But we were going to talk a lot about self-care and about what it's actually like to move from one country to the next, and how, what are some problems that you may come across or that you might find difficult during the transition, and some advice for someone who might be interested in doing that.
Yeah. And so it's going to be a lot of little things. The way we apply for a driver's license is slightly different. The way we tap on or tap off out of the bus is going to be slightly different. There's all these little, it's a very similar sort of society, but there's all these little subtle things which are different. So, And then we just sort of go from having lots of best friends around us to like, oh, I've got to now find a friend.
So what's it like? Yeah. So when you get employed by a service over there, so you commence employment and obviously you're working with a qualified officer after that. What's the period of training then before you actually go out and work on your your own? And then what happens after that? Who are you working with and what's the structure like?
So it's 1 month of induction where it's really just watching slides and all those sort of HR, health and safety sort of things, and just touching on all the clinical stuff. So it's 1 month. Then you go to a thing called OPC, where it's 2 newly qualifieds with like a more senior person. So it's 3 in the truck. And then I think that goes for maybe 3 months at a training center. And then you go on to a relief rota, which is sort of like somewhat in a geographical area or cluster. And then that goes for, I think, 2 years. And they try and have a skill mix sort of balance, but there's a shortage of paramedics over here, so that's not always achievable. But if you have a question, you always just call the clinical hub, or you call your team leader, or you sort of, encourage the patient to hospital.
So there's very much a system set up where you seek support, and you seek support constantly, especially if you're in a situation where you're not sure about what the best course of action is for that person. It sounds quite comprehensive, actually, really.
And then when you're newly qualified, there's also like a checklist to help you decide whether you can discharge on scene or you should convey. So there's, I've forgotten what it's called, but they have like this checklist. So if you're working to that, you have a good sort of framework. So also there's, from a personal point of view, when we come over here, we have this like wave of excitement of this new city and this new job, and we're starting a career. And then about a month or 2 in, reality sets in. And then there's a bit of a like realization that, oh my goodness, I've now got to do night work. I've now got to travel to work. So expect a high and then a low. And then you sort of come out the other side and it's like, okay, I'm now planning a holiday. I know a few friends. I've got myself sorted.
So the rosters seem very different to what we do out here, because generally what people do, full-time staffers do 4 shifts on and then 5 off, whereas yours is a little bit more mixed than that, isn't it?
Yeah, there's like you get given a pattern, so you will know whether you're doing a day late or a night or you're off, but just the station isn't always allocated. But what you can do in London is you can work an extra day. So if I'm off today and I'm bored and I've got nothing on, I can book onto a truck and I can do extra hours and then have them off down the track.
And which has been really beneficial because you've had some fabulous holidays by accumulating toil.
And it lets you also have a life outside of shift work. So you can choose every Sunday, I want to do this with my friends. So it's very, very good. And the annual leave structure is also good. You can get annual leave approved within 8 hours.
Wow.
As long as there's no more than 20% people already booked off. So there's really good opportunities to have life outside of work.
Oh, that's good. That sounds really good. Now, the question that I do ask, and I ask often within these interviews, is really just kind of seeking pearls of wisdom or advice that you might want to give the students, that when you look back at yourself when you were studying or when you were just commencing employment for an ambulance service, what do you wish that you'd have known in the start that you know now? What's something that you've learned along the way that you think might be really beneficial for them to know?
I think when we go to jobs, not every job will be a medical job. I think there will be a lot of jobs which are social jobs. So when you go to the job, sometimes when you read the job as it comes down, you go, oh, this could be a social job rather than something which is like, give certain drugs and look at it from a clinical point of view. So, and then sometimes the jobs will not read that interesting. Okay, or they might be really, you think, pathetic. But it's nice to live in a place where we safety net our community, and then not everybody is perhaps as high functioning or as informed as we are. So it's worth looking at it socially and then giving them some sort of direction or help to understand their health.
I really like that. I really like that take on it, because I think it's quite common as you see people continue their employment as they start working, you know, on a truck. The fact that, you know, that there's a high portion of the cases that you attend to each day that are not acute, you know, or you look at it and you think, oh, that doesn't deserve an ambulance, or that they don't need an ambulance or whatever. And looking at it from that perspective and thinking of it as a social job rather than being a medical job, I think that's a really good way of just shifting your mindset rather than looking at things negatively, because it's something that I know that we've conversed about before, that it's so common that you see over the years as people progress as paramedics employed, the negative mindset, you know, comes in, and that negative banter, it exists, and you see people talking like that, which is a really, I don't think it's a great way to be.
It even gets the individual down, you know, like it's, if you take the more humble approach, it's sort of good for our own happiness.
Yeah, I think so.
And like, somewhat, I also view our job as you're driving around the city with a mate, you're playing some music, having a bit of a joke, and then you're picking up people who are sick or giving them some help. Yeah. And then like, you know, trying to enjoy your day as well.
Yeah, exactly.
Rather than like getting angry that somebody called 999 or 111 for something that you think is pathetic. Yeah. So because,
exactly.
You know, they don't really want an ambulance in their lounge room. They'd rather be, you know, back to their life.
Yeah, and really, at the end of the day, when someone calls an ambulance, they're in a situation where they want someone to come and help them, they want assistance, or they're in a situation that they don't know how to handle. Like, it's, you know, that's just the bottom line, really, isn't it?
And, you know, in a more humorous way, like if we were to think about how many ambulances does Sydney or London need at any given hour, it's not that many. So we're probably, we said we need employment. So it's probably in our interest to have these social jobs.
Yeah, exactly. It's called job security. That's what I like to call it. This is a job security case rather than a medical acuity case.
Yeah.
No, we wouldn't need this many paramedics or this many ambulances if there weren't so many job security cases.
Yeah.
Now, just to round off, is there anything else that that you want to share with us today? I think this has been a really great conversation, and I'm sure that the students will get a lot out of it.
Yeah, look, I think if you're up for an adventure and you're prepared... Oh, and actually the other thing is, when we move to London, you know, try and get a friend outside of LAS, because they will be the friend that shows you England and London. And also, if they're from Europe, they will show you their home country in a whole new way. Yeah. And if you like a bit of travel, you can sort of say, like, you can really explore a country rather than just go to the capital city for a few days. Yeah. So,
that's a great piece of advice. I think we all need friends outside of the service. You know, you tend to get very, you get that tunnel vision. I know that most of us, when you first start working on road, that your AMBO friends tend to be the ones that overcome a lot, but that establishing friends outside of the service and making sure that you keep those connections is a really important thing to do. I agree with you. Yeah. Well, thanks so much for chatting with us today. It's been wonderful.
Cool. Okay. Thanks, Tara.
Thank you.
Thanks.